all see my slide?
Yes, we can.
Okay, thank you.
Yes.
Good afternoon, everyone, my senior colleagues and colleagues. And I would also like to thank the OSN for the opportunity to speak on this topic. So I'll be talking about uveitis management from the perspective of a retinal specialist. So as way of introduction, literally uveitis refers to inflammation of the uveal tract, which we all know, the iris, ciliary body, and choroid. However, we all know that almost all ocular structures, including the retina, vitreous, and optic nerve, will be involved in the inflammatory process. And as a result of this, uveitis actually straddles almost all specialties of ophthalmology, but it does so more with retinal subspecialty. And this is understandable, given the fact that based on the anatomical classification, your intermediate and posterior uveitis are actually within the domain of the retinal specialist. So I would like to start by saying that it's actually a multidisciplinary approach for uveitis and involves the uveitis specialist, the retinal specialist, the pediatric ophthalmologist, anterior segment surgeon, glaucoma specialist, your rheumatologist, the infectious disease specialist, and also your pathologist. So talking from point of view of the retinal specialist, I would say that the retinal specialist actually has a unique perspective on patients with uveitis, and because usually the retinal specialist will be the fallback option when there's no uveitis specialist, which I believe that's actually what obtains in most centers within the country. So actually, the retinal specialist actually ends up managing most of the uveitis cases. Maybe apart from the anterior uveitis, most people will probably be comfortable managing anterior uveitis, but once there's anything behind the iris, they probably send to a retinal specialist. And usually, because the retinal specialist, most of examination involves making a diagnosis, like your indirect ophthalmoscopy with indentation, the slit lamp biomicroscopy. There are actually things that we carry out every day in our clinic. So it's like it's just what we're used to doing. Then also the investigations required in making your ocular diagnosis, the ocular bead scan, OCT, fundal fluorescein angiography are things that we use. These are tools we use every day for our patients. So it's just part of the whole process. Then our interventions, like your intravitreal injections, your intravitreal implants, and posterior segment surgeries are things that you use for your patient day in, day out. So it's just like a continuum. So I'll just mention briefly the anterior, intermediate, and posterior uveitis. So anterior uveitis is defined anatomically as intraocular inflammation, in which the predominant site is anterior chamber. And this actually makes up majority of uveitis cases, 60 to 90%. Usually, you can make your diagnosis clinically, but I would like to stress that it's actually important for you to examine the posterior segment so that you do not label the anterior signs of an intermediate or posterior uveitis as an anterior uveitis. So you actually make your assessment of an anterior uveitis after examining the posterior segment, and you're sure that there's nothing there. All you have is an anterior uveitis. That's when you can actually say you have an anterior uveitis. Then for the intermediate uveitis, usually the inflammation is concentrated in the ciliary body, the pars plana, and your peripheral retina. Usually you see inflammatory cells in the anterior vitreous, but the hallmark sign is aggregation of inflammatory cells in the vitreous, your snowbank, and inflammatory exudates in the pars plana, which is your snowbank. So this accounts for up to about 15% of cases of uveitis, and it's bilateral in up to 80% of cases. So if you see sign in one eye, you should actually go back and examine the other eye carefully, because it's usually bilateral. And if you examine the fellow eye, even if you see just a few vitreous cells, then you should consider it to be bilateral, just that it's asymmetrical. So what are differential diagnosis for and intermediate uveitis, of course, could be like so Onokwe pointed out, infectious, non-infectious, and your masquerade syndrome. Infectious will include your syphilis, tuberculosis, Lyme's disease. Non-infectious will include your pars planitis. Pars planitis is actually idiopathic intermediate uveitis. Then, of course, if you have your sarcoidosis, your Behçet's disease, and multiple sclerosis, then your masquerade syndrome will include your intraocular lymphoma, leukemia, and retinoblastoma. So for posterior uveitis and panuveitis, in posterior uveitis, inflammation is primarily involving the retina and the choroid. And posterior uveitis makes up about 7% of all cases of uveitis. And compared to the anterior and intermediate uveitis, the list of probable diagnosis is much longer. It probably has the highest number of probable diagnosis you can have. While when you talk about panuveitis, it means inflammation involves all the anatomical components of the eye, the anterior chamber, vitreous, retina, and the choroid. So the differential, right? I just listed a few of them, but there's so many of them, so many: your toxoplasmosis, endophthalmitis, TB, toxocariasis, acute retinal necrosis, CMV, your non-infectious sarcoidosis, sympathetic ophthalmia, Behçet's, VKH, and your white dot syndrome, and also we should not forget systemic lupus erythematosus. So actually, for the posterior uveitis, some form of posterior uveitis could be could lead to very rapid visual loss if they are not treated on time. So it's actually, if you think you're dealing with the posterior uveitis, it's actually important for you to rule out this ones that cause very rapid visual loss. And there's actually 3 of them. You have your infectious endophthalmitis, and this, we know this could actually be post-operative or endogenous. Post-operative, of course, you want from the history of a recent ocular surgery or intravitreal injection. Nowadays, there's so many centers that giving intravitreal injections, so that's there's a risk of endophthalmitis in such cases. Then, of course, for example, if the patient had a previous trabeculectomy, so might not be recent, it could have been done years ago, and they could have endophthalmitis. Then, of course, your endogenous endophthalmitis, you have to think of focus of infection in other parts of the body. Then it could also be seen in intravenous drug users. Then also people with immunosuppression. Then your viral retinitis. They include your acute retinal necrosis, your progressive outer retinal necrosis, and your CMV retinitis. And the viral, especially your acute retinal necrosis, it actually progresses very rapidly. So it's actually something not to be missed, because if you miss it, by the time patient comes back a couple of days later, a couple of weeks, then probably it's probably too late to do anything about it. So it's actually very important to pick these cases. Then of course your toxoplasmosis is actually the commonest cause of a posterior uveitis, but some cases, like if you have a lesion that's close to the macula, optic disc, or a major retinal vessel, or when you have severe vitritis, or in immunocompromised patients, you should actually treat this 3 promptly. So when you think you're dealing with posterior uveitis, it's important you rule out these 3 main ones, because if you miss them, then you probably end up losing the patient. End up losing that eye. So this is just to demonstrate how rapidly this is a case of acute retinal necrosis. The first picture on your left is actually on day 1 that patient presented, but you can see by day 3, just 48 hours later, you can see how fast it is spread. Usually it starts from the periphery and moves towards the posterior pole. So if it's not picked up on time, it will actually involve the posterior pole, and it will cause a severe visual loss. So we'll briefly look at diagnostic difficulties in uveitis. Like Professor Onokwe pointed out, the uveitic entities could actually present with similar clinical features, but they could have a different treatment and prognosis. So making an accurate diagnosis is actually very important. Like she pointed out, if, for example, you have a patient that has a infectious uveitis, and you end up giving steroid, you could actually make the whole thing worse. So because usually if it's an infectious uveitis, apart from you're supposed to give an antibiotic or antimicrobial concomitantly while you give your anti-inflammatory. So it's actually important to differentiate the disease, whether it's autoimmune, infectious, or it's a malignant ocular process. So what are some of the diagnosis surgical procedures that help in making a diagnosis? Of course, the first one I'll talk about will be the vitreous tap. So Nokwe has spoke about the anterior chamber tap earlier, vitreous tap. So now it's vitreous tap. We're all familiar with this because usually when patients have post-operative endophthalmitis, that's what we usually do. We usually do a vitreous tap using a needle and syringe. Of course, it's easy to perform. You don't need much to do it. But usually it provides a very small sample because it can't take out much without causing hypotony in the eye. Then, of course, because you're just applying traction to the vitreous, there's a risk of retinal detachment and also hypotony. Then the second one I would like to talk about is the vitreous biopsy or diagnostic pars plana vitrectomy. Usually, you take you require a vitrectomy, normal vitrectomy setup, and you attach a syringe to the initial sample you take so that it's undiluted. So usually the vitreous biopsy will give you a much larger sample, and of course you could actually go on and do a vitrectomy, total vitrectomy for the patient. So ends up being therapeutic as well. So this is just a slide showing how the vitreous biopsy or diagnostic PPV is done. A is you can see the syringe attached to the vitreous quarter. B, you can see the arrow showing the attachment. Then C is the sample that was obtained from the process. So the other one I would like to talk about is your retinal biopsy, and this could actually be done when in some cases where the inflammatory process is localized primarily within the retina or the choroid. So in such cases, the vitreous sample might not give you any yield, and it could be performed from within the eye. While you do your vitrectomy, then you go and just take a sample of the choroid or the retina, and it will also be done from externally through the sclera. The one done from outside through the sclera is actually done in cases where it's very anterior, close to the inverse, so that you have easier access. But if it's posterior, then it's better to actually go from within. And if you're going from within, it's preferred that you take the biopsy from superior location, and of course, obviously away from major blood vessels. This is just a slide showing the colorectal biopsy. The first one, you can see, this is going from within now. You can see the sample being taken. The sample is being in A now. The sample is being brought out through a sclerotomy. Then B is, this is actually the sample placed on a filter paper. And the lower slide is showing patient 6 months after the biopsy was taken. So you can see the coloretinal scar from where the biopsy was taken. Such procedures are actually generally undertaken only when non-invasive ones fail to give you a diagnosis. This is not, a patient doesn't just come and you just decide, okay, the first thing I want to do is take a coloretinal biopsy. You only do it when you're not able to get a diagnosis. And the sample acquired is subjected to microbiology, PCR, cytopathology, flow cytometry, and immunohistochemistry. But of course, you need to have appropriate laboratory backup and also the personnel to handle the sample. I mean, there's no point going through so much trouble to get a sample that if it cannot be adequately processed to give you a diagnosis. So what are the indications for doing this test? When you have cases that present atypically, then when the patient does not respond to empirical treatment, or when you have very rapid progressive disease, or when you have a strong suspicion of a malignancy. So we'll look at some of the complications of uveitis. Of course, we know with chronic intraocular inflammation, structural damage will inevitably occur in many eyes. And vision loss in uveitis results from multiple complications involving almost all intraocular structures. And a significant proportion of these complications will require surgical intervention. So for patients that need to have any type of surgery, uveitis patients that need to have any type of surgery, the most important part of the management will be your perioperative control of the inflammation. And you get your best surgical outcomes when you have a good control of inflammation. So this actually requires close collaboration between the uveitis specialist and the surgeon performing the procedure. I mean, uveitis patients usually require surgery for so many things. You have your uveitic cataract, you have your uveitic glaucoma, you have your band keratopathy. So they actually need to have surgery for a lot of conditions, and it's important. It's a very important part of management is perioperative control of the inflammation before the surgery, during the surgery, and afterwards. So what are some of the therapeutic vitreoretinal procedures that carried out for patients with uveitis? Of course, we're all familiar with intravitreal injections. We just spoke about endophthalmitis. Usually, you give your intravitreal antibiotics. Then, for cases like your viral retinitis, you give antiviral intravitreal injections. Then, also for fungal endophthalmitis, you give antifungal. Then, usually, like for your cystoid macular edema, you give your steroids, and you could also give your anti-VEGFs. Then, of course, you also have your sustained release intravitreal implants, like your Ozurdex, which is dexamethasone, releases dexamethasone gradually over like 6 months in the vitreous. Then you have your Retisas, which is fluocinolone. This actually releases the steroid over like 3 years. Then you have your Vitrasat, which is aciclovir, which is an antiviral and releases it over about 8 months. Now, of course, you have your therapeutic vitrectomy. So what are the indications for therapeutic vitrectomy? There's so many of them. You have your endophthalmitis, you have your cyclical membranes, especially in patients with intermediate uveitis. Then you have your cases of refractive uveitic macular edema, of course, retinal detachments, epiretinal membranes, and your vitreous opacification. So briefly look at cyclic membranes. Usually may result in chronic hypotony from traction on the ciliary body. It's common in intermediate uveitis and is usually best assessed using ultrasound biomicroscopy. You can see the picture below. There's an arrow pointing to cyclic membrane, which is putting some traction on the ciliary body. So in this patients, there actually increased risk of chronic hypotony, and it could eventually go on to result in actinic bulbar. The treatment use long-term local steroid administration. So actually use the side effect of steroid, which is rise in intraocular pressure, as a treatment in this case. Then you could also release the membrane surgically. Then in patients, you could actually do a vitrectomy with long-term tamponade with silicone oil in eyes where the ciliary process are atrophic, in order to maintain the ocular anatomy and IOP. So uveitic macular edema, it's like it's been pointed out, it's a common cause of visual loss and may arise from uveitis of any location or any etiology, and it's mediated by inflammatory cytokines like your VEGF and interleukin-6, and also less commonly it could be from vitreomacular traction. Usually, it's evaluated and monitored using the OCT and fundal fluorescein angiography. The treatment is actually to treat the control the intraocular inflammation. But if the edema persists, then you could give treatment that specifically targets the uveitic macular edema. And this includes your periocular steroids, your corticosteroids, and all what have you. You could also use your intravitreal steroids. Then also corticosteroid steroid implants. You could also use your intravitreal anti-VEGFs. Then past planar vitrectomy, but this is usually reserved for cases where you have a retinal membrane or vitromacular traction addition, because those ones will actually not resolve with your medical therapy. So this is just a slide. The first one is showing a patient with actually has a posterior uveitis, which actually toxoplasmosis, where you can see patient has a macular edema, but you can see on the surface there's actually an epiretinal membrane. This kind of case will not resolve with your medical therapy. You might need to offer this patient surgery to relieve the infection. Then the next one there is showing a patient with vitromacular traction. So I'll also like to talk briefly about retinal detachment in uveitis. Of course, it's very common. Could be rheumatogenius or tractional, which is seen in your viral retinitis, your acute retinal necrosis, CMV retinitis, vasculinitis, toxopariasis, and also infectious endophthalmitis. Then you could have exudative in your BKH, sympathetic ophthalmitis, and posterior scleritis. So it's commonly seen in viral retinitis, and detachment rates of up to 33% have been reported following CMV retinitis, and up to 75% in acute retinal necrosis. In vasculinitis, up to 10% could develop a retinal detachment from fibrosis and fractional membranes overlying the peripheral retina. Then 8% and 25% are reported for bacterial and fungal endophthalmitis, respectively. So usually in retinal detachment in patients with uveitis, you usually have high rates of PVR, and because of the inflammatory process, there's poor visualization and ongoing inflammation. So this actually makes surgery in such patients very challenging. So it's essential to control the inflammation aggressively in the perioperative period. And usually in patients with uveitis, they don't do so well. The single operation reattachment rate is about 59%, and final anatomic reattachment rate about 88% in uveitic patients, compared to about 85 to 94% single operation success rate in non-uveitic patients, and 95 to 100% of final anatomic rates in non-uveitic patients. So this is just a case of acute retinal necrosis. You can see that the first slide, you can see the yellowish area in the periphery, in the temporal periphery. That's a case of acute retinal necrosis. And you can see in the second slide, patient has a retinal detachment following the acute retinal necrosis. And in the last slide, patient had a vitrectomy, and the retina is now flat. So another indication for vitrectomy in patients with uveitis is when you have vitreous opacification, and this will lead to persistent debris and opacity within the vitreous, and this could be visually significant. And also, we know this could actually hinder evaluation of the posterior segment in such patients. So in conclusion, I would like to state that the marginal uveitis and its complications will actually be quite challenging. So in order to ensure that patient care is optimized, a multidisciplinary approach is actually essential for such patients. Thank you for listening.